side of the hemithorax. Okay. Then so during inspection, during inspection, what we are seeing that there is a fullness of the right side of the hemithorax. Okay. And percussion, as I have already told, it is a direct percussion. And over the manubrium is direct percussion, over the body again there is a direct percussion. And after that we will percussion should start from normal side and compare it with the abnormal side. This is resonant. There is a dullness. So what you are looking, again there is a resonant note on the right side and dullness from the fourth intercostal space downwards. But what is peculiar in this case is that there is process spirit. Now percussion over the trough space. It is tympanator. So trough space is present. Okay. And in the right side, again the liver dullness you have to percuss, and it is the deep percussion, not the light percussion. This is, and again you have to measure from second, third. This is second space, third space, fourth space, and fifth space. So liver dullness is from the space. In the axilla, you have to look for the hand. In the axilla, you have to percuss over the mid axillary line. So there is anterior axillary fold and posterior axillary fold. It should be, you can, this is anterior axillary fold and posterior axillary fold. You have to draw a line in between and then percuss. So in the mid axillary line, you have to percuss from fourth to eighth space, and there is dullness from the fifth space downwards. Fifth space downwards, and then percuss from the back. How to percuss from the back? Place the hand like that. Then, in the supraclavicular, the suprascapular area, again you can percuss over the middle of the trapezius muscle. Okay, in the interscapular region, the finger should be placed horizontally. Both sides equal. Okay, there is a scar mark. You have to mention it in John survey. In the infrascapular, you have to percuss like that. Fist. There is a dullness over the infrascapular area. Then, which space? This is the terminal angle. So this is the second space. This second space downwards. So you have to put a marker here. If you have to put a marker here in the mid axillary and put a marker here. If the lines, then draw a line. If the lines are horizontal, then you can say it is the horizontal fluid. Okay, horizontal fluid level not always found in case of hydropneumothorax, because it may be encysted. In case of encysted hydropneumothorax, you will not get horizontal fluid level. And after that, after getting that, Whenever there is a dullness, you have to demonstrate that the dullness shifts. How to look for that? You have to percuss over the you have to percuss over the mid axillary line and demonstrate and this is throat percussion. Done. Then place this. Okay, and ask the patient to lie in the lateral decubitus position. And in lateral decubitus position, patient after 3 normal breath, you again percuss it. And percussion you will get, if you get any change of the note from dull to resonant note, then you can say that the dull note is replaced by resonant note, means fluid is replaced by air. Again you have to place the patient without moving the finger, again percuss over there, and again if you get dull note, then you can say that is a hyperresonant to dull note. So it is fluid, air is again replaced by fluid, and that is indication of shifting dullness. So shifting dullness, you have to demonstrate that fluid is replaced by air, and again air is replaced by fluid. So shifting dullness may be immediate shifting dullness. Immediate shifting dullness occurs in hydropneumatics, but it may not be. Number one, if it is insisted, you may not get it. If the fluid is thick, then you may not get it. Okay, or if the air is small or the fluid is small, in those cases you may not get it. And another is the delayed shifting dullness. Or delayed shifting dullness, you have to put the patient on lateral decubitus position for at least 20 to 30 minutes. After that you will percuss. Then why this delay is required? Because the resonant node is due to air. In hydropneumothorax, air and fluid both are in the pleural space, so that is immediate. But in pleural effusion, what happens? The collapse alveoli will have to be aerated, and that will take some time. So, if the delayed shifting dullness is present in pure pleural effusion, it indicates that underlying alveoli are healthy, or underlying lungs are healthy, and that is a good prognostic. Okay. Then the special type of percussion, one is liver dullness percussion, another is top space percussion, another is chronic isthmus percussion. So how to percuss chronic? Before that, I can say one thing. If top space, you can get top space, hyperresonant or tympanic top space, then you think 3 to 4 times before telling it is a prolongation. We have sometimes insisted effusion, particularly loculated posteriorly, but you have to think twice before telling that it is a left-sided prolongation. And the chronic isthmus, what is the chronic isthmus? It is the space between, anteriorly it is the clavicle, medially it is the neck muscles, laterally acromion process, and posteriorly the trapezius muscles. So percussion over the chronic isthmus, again you have to place this finger in the and then percuss over it. Okay, this is chronic and it should be resonant. Chronic isthmus was once thought to be the dullness over the chronic isthmus, usually at that time was thought to be a sign of tuberculosis. Or apical, now we know that apical pleural fibrosis may also give rise to the dullness of the chronic isthmus. Another condition is the superior sulcus tumor. Another is the tidal percussion. Tidal percussion is very difficult one. First you have to percuss the normal side. And get the lower border of the lung. After that, You ask the patient wants to take deep inspiration and deep expiration. জোরে শ্বাস নিয়ে ধরে রাখুন তো, জোরে ছাড়বেন না। হ্যাঁ, এগেন পারকাস ছেড়ে দিন পুরো, এবার ধরে রাখুন, নেবেন না, ছেড়ে ধরে রাখুন। Okay, so during inspiration it is resonant and during expiration it is done. And there will be one space difference between inspiration and expiration. It is very difficult to appreciate, and in examination it is better to avoid. After percussion, there is auscultation. Again, for auscultation, there are three things. You first demonstrate how to breathe. Then ask the patient to do it and observe whether the patient is doing it properly or not. যে জোরে জোরে লম্বা করে শ্বাস নিন, এই যে আমাকে দেখুন, আচ্ছা নিন, মুখ দিয়ে শব্দ করবেন না, আস্তে করে you have to again start auscultation anteriorly in the intraclavicular and mammary, sometimes inframammary or axillary, intraaxillary, suprascapular, interscapular, intrascapular. Again from normal side first, then abnormal side. First means একটু বললাম, this is mammary. Inframammary is not so important because it is covering the, this is axillary, this intraaxillary. And this is suprascapular. You have to look for three breaths. You have to, in each area, you have to look for three breaths, and along with the breath sound, you have to look for if there is any added sound, repetition, mainly the repetition, ronchi and roll. If they are present, you have to mention it. And if there is any other type, and after that, you have to look for vocal resonance. How to do that? আপনি আগের মতো একটু তিন 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 বলবেন, হ্যাঁ, তিন তিন যেরকম দেখিয়ে দিয়েছিলাম, তিন তিন তিন, and compare it. Now one is the whispering victory. If any condition in which there is bronchial bass sound, you have to confirm it by bronchial bass sound by whispering victory. You ask the patient to whisper, and you will see, you hear this faintly. If when you can hear this distinctly, then it is whispering victory positive. So how to whisper? That is the most important thing. You have to demonstrate later. Again, then you have to. Okay. And another auscultative finding is, in case of hydropneumothorax, is the subcussion class. How to look for subcussion class? You have to at the border of the ear and fluid, and then you have to do a sudden jerk. Okay, sudden jerk, and you can see the flushing sound. So subcussion class may be present in hydropneumothorax, may not be present in insistent thick fluid. Okay, and in normal person you can get the subcussion class, particularly in full stomach. If you take lots of fluid after that, you may get subcussion class. One thing I have left is another is the, so what are the things you look for during auscultation? Number one, bass sound. Number two, added sound. Number three, vocal resonance. in the breath sound, we know that breath sounds are of three types: bronchial breath sound and vesicular breath sound. Vesicular breath sound, we know that it is a rustling character, there will be no gap, and the expiratory part is shorter than the inspiratory part. But there is also the prolonged expiration. So, vesicular breath sound will prolonged expiration in which the expiratory part is prolonged. In bronchial breath sound, পজ করেছিল তো?
পজ